السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. This is a video recording for the physiology lecture on cardiac arrhythmias in the cardiovascular block. These are the active learning objectives, the intended learning outcomes, ILOs for this learning activity, and here as usual we have the recommended learning resources. We have defined what is meant by cardiac rhythm in the lecture on the ECG. The term rhythm refers to the regularity of the initiation of the cardiac impulses and the regularity of the sequence of excitation of the heart. It hence refers to the regularity of the electrical activity of the heart. The normal cardiac rhythm is called the normal sinus rhythm, and any variation from the normal sinus rhythm is termed a cardiac arrhythmia or a cardiac dysrhythmia. The heart has normal sinus rhythm when all the cardiac impulses originate in the sinoatrial node regularly at a rate of approximately 60 to 100 beats per minute in normal adults at rest. The normal sinus rhythm is defined by the ECG as a rhythm which shows P waves which are upright and of uniform size and contour from beat to beat. So this ECG shows a normal sinus rhythm. All the P waves are upright and of uniform size and uniform shape or contour from beat to beat. Similarly, this ECG shows a normal sinus rhythm. Each P wave is followed by a QRS complex, resulting in a ratio between the P waves and the QRS complexes of 1 to 1. Also, the normal sinus rhythm shows that all complexes are evenly spaced, hence the time interval between the successive P waves and the time interval between the successive QRS complexes are equal. The PR interval in a normal sinus rhythm is constant and within the normal range of duration. Having known what is a normal sinus rhythm and what is meant by a cardiac arrhythmia or a cardiac dysrhythmia, let us classify cardiac arrhythmias or cardiac dysrhythmias. Cardiac arrhythmias can be classified in different ways. One way to classify cardiac arrhythmias is to classify them based on the mechanism. And under this classification, cardiac arrhythmias are classified into arrhythmias due to alterations or disturbances of impulse formation and arrhythmias due to alterations or disturbances of impulse conduction. Arrhythmias can be also classified based on the origin, and this is what is known as the anatomical classification of the arrhythmia. Based on the origin, arrhythmias can be classified into supraventricular arrhythmias and ventricular arrhythmias. The supraventricular arrhythmias are further subclassified into atrial arrhythmias and atrioventricular AV arrhythmias, which are also known as junctional arrhythmias. Hence, arrhythmias which are due to alterations or disturbances of impulse formation, and similarly arrhythmias which are due to disturbances of impulse conduction, could be supraventricular arrhythmias or ventricular arrhythmias. A third way of classifying cardiac arrhythmias is based on the heart rate while the arrhythmia is present. Arrhythmias could be classified into bradyarrhythmias and tachyarrhythmias. arrhythmias. The most important classification of the cardiac arrhythmias is the classification based on the mechanism of the arrhythmia. And hence we shall describe now these mechanisms in details. And let's begin with the arrhythmias which are due to alterations or disturbances of impulse formation. These arrhythmias are further subclassified into arrhythmias due to alterations in the AC node pacemaker activity and arrhythmias due to enhanced automaticity of the AV junctional tissue and arrhythmias due to triggered activity and re-entry. Thus, the mechanisms of arrhythmias due to alterations or disturbances of impulse formation include enhanced automaticity, triggered activity, and reentrant circuits, which are also known as physiologically as circus movements. The arrhythmias which arise due to the reentrant circuits, due to the circus movements, can be also considered as arrhythmias due to disturbances of impulse conduction, as we will describe in the subsequent slides. However, now let's focus on reentrant circuits, on the circus movement, as a mechanism of the arrhythmias which are due to alterations or disturbances of impulse formation. Now let's very briefly describe these three major mechanisms of arrhythmia. Enhanced automaticity is defined as an inappropriate increase in the rate of discharge of cardiac impulses of a cardiac tissue having physiological pacemaker properties, like when there is enhanced automaticity of the sinoatrial node, or the enhanced automaticity can involve the atrioventricular node or Purkinje fibers. Triggered activity is defined as the appearance of automaticity as a result of external stimulation, and this appearance of automaticity might arise in tissues that do not normally demonstrate physiological automaticity. Re-entry or reentrant circuits, which are also known as Lewis circus movements, these occur when a cardiac impulse re-excites some region of the heart through which the impulse has already passed in that particular heartbeat. For a reentrant circuit to develop and cause an arrhythmia, a unidirectional or a partial conduction block is required. And once started, re-entry may generate a self-initiating and self-sustaining action potential that propagates as a wave around the heart. Let's describe the mechanism of re-entry by unidirectional block in more details. Depolarization of a ring of cardiac tissue is shown in this right panel of the figure. Normally the impulse, the cardiac impulse, spreads in both directions in the ring, and the tissue immediately behind each branch of the impulse become refractory. However, when a transient block occurs in one side, this is a unidirectional block because the block has occurred in one side only, the impulse on the other side goes around the ring, and if the transient block has now worn off, the impulse passes this area and continues to circulate indefinitely, initiating a circus movement or a re-entry circuit. Let's describe re-entry in further more details. In bidirectional block, the impulse may not be conducted through the region of cardiac tissue. So the impulse will not be conducted in the antegrade direction, and it will not be also conducted in the retrograde direction. So this is bidirectional block. This bidirectional block will not initiate a circus movement. A circus movement will be initiated if there is a unidirectional partial block. Bidirectional block is generally due to intense vagal stimulation, or it happens as a result of cellular damage, which is often due to cell death of the myocardial tissue, as in myocardial infarction. In unidirectional block, the impulse is blocked in the antegrade direction. So the impulse doesn't pass in the antegrade direction because this area is not allowing the impulse to pass through. But the impulse might propagate slowly through the retrograde direction, because by the time the impulse reaches the unidirectional block area, the area might now allow the impulse to pass through the retrograde direction, and hence beginning a re-entry arrhythmia. This is often seen when the region of the cardiac tissue is only damaged but not yet dead, as what happens when there is myocardial ischemia. In the ischemic myocardial tissue, metabolic waste products are not removed, hence lactic acid builds up inside the cells, and this causes an acidic cellular interior which closes the gap junctions which the cells have in the intercalated discs. Accordingly, the refractory period in this ischemic tissue may be out of synchrony with the surrounding tissue, and this now causes a unidirectional block of the conduction. So the impulse is only blocked in the antegrade direction and not in the retrograde direction. How do we treat unidirectional block in order to prevent the development of reentrant arrhythmias? We give the patients a drug known as lidocaine or lignocaine, and this drug blocks diffuse sodium channels firing and hence allows a bidirectional block to develop in the ischemic tissues. Now let's describe the first category of arrhythmias due to alterations or disturbances of impulse formation, which are arrhythmias due to alterations in sinoatrial node pacemaker activity. These arrhythmias due to alterations in sinoatrial node pacemaker activity include sinus bradycardia, sinus tachycardia, and sinus arrhythmia, which is also known as respiratory sinus arrhythmia. Let's begin with the description of sinus bradycardia. Sinus bradycardia is defined as a sinus rhythm with a heart rate slower than 60 beats per minute. The causes of sinus bradycardia could be physiological, and it could be pathological or pharmacological. Physiological sinus bradycardia occurs in healthy individuals who are usually athletes with increased vagal tone and in most people during deep, quiet sleep. The pharmacological and pathological causes of sinus bradycardia include structural sinoatrial node disease or ischemia, and this is clinically known as sick sinus syndrome or AC node disease. Increased vagal tone due to vagal stimulation, or example, due to drugs. Beta blockers also cause sinus bradycardia. Other pharmacological and pathological causes of sinus bradycardia include acute myocardial infarction, hypothermia, hypothyroidism, raised intracranial pressure, obstructive jaundice, and uremia. And we have explained the mechanism of sinus bradycardia when the intracranial pressure is raised in the 2 lectures on arterial blood pressure. The symptoms of sinus bradycardia include dyspnea, dizziness, and extreme fatigue. Now let's see how sinus bradycardia appears in the ECG. This is sinus bradycardia, and here in this ECG strip it is also sinus bradycardia because we have P waves, and each P wave is followed by a QRS complex. However, the heart rate, this is not a normal sinus rhythm. This is sinus bradycardia because the heart rate is extremely slow. We can use the ECG to determine the heart rate by dividing 300 by the number of large squares between 2 successive R waves. So the number of the large squares between these 2 R waves is 1, 2, 3, 4, 5, 6, 7, 8, 8.5 large squares. And when we divide 300 by 8.5, this gives a heart rate of 35 beats per minute. In this ECG, the number of large squares between 2 successive R waves is approximately 10 large squares, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So 300 divided by 10, the heart rate is 30 beats per minute. Now let's describe the other arrhythmia due to altered sinoatrial node activity, which is sinus tachycardia. Sinus tachycardia is the cardiac arrhythmia which arises because of enhanced automaticity of the sinoatrial node, and the heart rate is faster than 100 beats per minute. The causes of sinus tachycardia include physiological causes and pharmacological and pathological causes. Physiological sinus tachycardia is seen during exercise and with sympathetic stimulation, and also during pregnancy. The pharmacological and the pathological causes of sinus tachycardia include any cause of adrenergic stimulation, including pain, anticholinergic drugs like atropine, which block the muscarinic M2 receptors in the sinoatrial nodal cells, vasodilator drugs, including many hypotensive agents, many antihypertensive agents which lower the arterial blood pressure, thyrotoxicosis, hypovolemia, anemia, fever, and myocarditis, which is inflammation of the myocardial tissue. As I've just mentioned, sinus tachycardia results from increased automaticity, from enhanced automaticity of the sinoatrial node. And here we have a 12-lead ECG showing sinus tachycardia. So it is a sinus rhythm but it is not a normal sinus rhythm. It is a sinus rhythm because we have P waves. These are P waves in the different ECG leads, and each P wave is followed by a QRS complex. The number of the large squares between two successive R waves is approximately 2.5 small squares, and this gives a heart rate of about 120 beats per minute. Now let's describe the third arrhythmia, which results from altered activity of the pacemaker, and this is the sinus arrhythmia, which is also known as the respiratory sinus arrhythmia. Respiratory sinus arrhythmia is defined as an increase in the heart rate during inspiration and a decrease in the heart rate during expiration. It's a normal finding in children and young adults, and it tends to diminish or disappear with age. The mechanism of the respiratory sinus arrhythmia is due to variations in the vagal tone that affects the sinoatrial node during inspiration and expiration. And here we have an ECG strip which shows respiratory sinus arrhythmia. So now this is the heart rate during expiration, and this is the heart rate during inspiration. We can again calculate the heart rate by dividing 300 by the number of large squares between two successive R waves. Here we have 1, 2, 3, 4, 5, 6, 7, and this gives a heart rate of about 42 during expiration, and during inspiration the heart rate might reach up to 100 beats per minute. So now we have finished with the description of the three major arrhythmias which arise from altered activity of the sinoatrial node pacemaker activity. And now let's describe the other important category of cardiac arrhythmias due to alterations or disturbances of impulse formation. And this important category of dysrhythmias include dysrhythmias due to triggered activity and dysrhythmias due to reentrant circuits. They are further subclassified into atrial extrasystoles, which are also known as atrial premature beats, or atrial premature complexes, or atrial premature contractions. Similarly, we have ventricular extrasystoles, which are also known as ventricular premature beats, or ventricular premature complexes, or ventricular premature contractions. In this category of arrhythmias, we also have atrial tachycardia in the form of supraventricular tachycardia, and similarly we have ventricular tachycardia. We also have atrial flutter. There is no ventricular flutter. In this category of arrhythmias, we also have atrial fibrillation and ventricular fibrillation. This important category of cardiac arrhythmias can thus be further subclassified into supraventricular arrhythmias or atrial arrhythmias and ventricular arrhythmias based on the origin of the arrhythmia. Atrial arrhythmias show narrow QRS complexes in the ECG, and ventricular arrhythmias show wide QRS complexes in the ECG. This is a very important distinguishing feature between atrial arrhythmias and ventricular arrhythmias. Now let's describe these arrhythmias very briefly. Atrial and ventricular extrasystoles are also known as premature beats or premature contractions or premature complexes. A premature beat is an abnormal beat which occurs prematurely during the diastole of the previous beat. In other words, it occurs before the expected sinus beat happens. They are caused by abnormal impulses generated in a hyperexcitable focus in the atrial or ventricular myocardium. This is what we call physiologically an ectopic focus. They can be also caused by re-entry. If the focus is in the ventricles, the premature beat is called ventricular premature beat, and if the focus is in the atria, the premature beat is known as atrial premature beat. We shall now first describe atrial premature beats, then we will describe atrial tachycardia, the supraventricular tachycardia, followed by atrial flutter, then atrial fibrillation, and when we finished with describing the atrial arrhythmias, we shall move on to describe these important ventricular arrhythmias. An atrial premature beat is an abnormal beat which arises from one of the atria and occurs before the expected sinus beat. This is how an atrial premature beat or an atrial extrasystole appears in the ECG. This is a normal beat. This is a normal beat. This is a third normal beat. So now after the T wave represents ventricular repolarization. The ventricles begin with diastole, and while the ventricles are in diastole, an ectopic focus in one of the atria generates a cardiac impulse which results in a premature beat before the expected normal sinus beat. This is how a premature atrial beat looks like in the ECG in another ECG lead. This is a normal atrial beat. This is another normal atrial beat. And this is a premature atrial beat or a premature atrial complex or a premature atrial contraction, or is also known as atrial extrasystole. Having finished with the description of atrial premature complexes, the atrial extrasystoles, now let's describe supraventricular tachycardia, SVT, which is also known as paroxysmal supraventricular tachycardia. This arrhythmia is further subclassified into atrial tachycardia and junctional tachycardia, which might arise as a result of re-entry through the AV node or enhanced automaticity of the AV junction. Paroxysmal supraventricular tachycardia, SVT or PSVT, is most common among young people and is more unpleasant than dangerous. It may occur during vigorous exercise, and it is physiologically and clinically described as being paroxysmal arrhythmia because it is characterized by an abrupt onset and an abrupt termination. The overall heart rates vary from 150 to 150 beats per minute, and the most common range is from 160 to 200 beats per minute. This is a 12-lead ECG showing paroxysmal supraventricular tachycardia. The heart rate is approximately 150 beats per minute because we have two large squares between the successive R waves. The rhythm is regular, and I cannot see P waves in any of the leads of this 12 leads ECG. And hence, this arrhythmia should have not arisen from the sinoatrial node. Otherwise, we would have seen P waves, and the arrhythmia would have been a sinus tachycardia rather than a paroxysmal supraventricular tachycardia. This arrhythmia should have been arisen because of a hyperexcitable ectopic focus in one of the atria, or because of a re-entry circuit in one of the atria. Now let's describe atrial flutter. Atrial flutter occurs when the atria are stimulated to beat at a rate of about 200 to 350 beats per minute. The mechanism of atrial flutter is usually a circus movement in one of the atria. Atrial flutter results in poor atrial pumping, since some parts of the atria would be relaxing while other parts are contracting. Here we have the atrial flutter in an ECG strip. This is how atrial flutter looks like in the ECG. Here we have another ECG strip showing atrial flutter. So the P waves here are saw-toothed P waves. They look like the teeth of the saw. Now let's describe what is atrial fibrillation, AF. Atrial fibrillation occurs when the atria are stimulated to beat repeatedly and in an irregular and controlled manner, usually at an atrial rate which is greater than 350 beats per minute. The mechanism of atrial fibrillation usually involves micro re-entry at several ectopic foci in the atria that fire independently. As a result, atrial contractions would be asynchronous. Atrial contraction will be not synchronized, and this results in ineffective atrial contractions. The chaotic atrial depolarization waves penetrate the AV node in an irregular manner, resulting in irregular ventricular contractions. Sometimes some of the ventricular beats come very close together that little filling can occur between the beats. And when less filling occurs, the subsequent contraction would be weaker based on the Starling mechanism, and in fact some of the ventricular contraction may be too weak to eject enough blood to produce a palpable wrist pulse, and this gives what is known as pulsus deficit clinically. This is how atrial fibrillation looks like in the ECG. This is a T wave. This is also a T wave. This is a T wave. These are all T waves, and I cannot see normal P waves. Rather, there are what are known as the F waves of atrial fibrillation. One of the important characteristics of atrial fibrillation is the absence of the P waves. Another very important characteristic of atrial fibrillation is that the ventricular rate is not regular, because as I've just mentioned, the chaotic atrial depolarization waves penetrate the AV node in an irregular manner, resulting in irregular ventricular depolarizations followed by irregular ventricular contractions. So now let's move on and describe the ventricular arrhythmias, and let's begin with describing the ventricular extrasystoles, which are also known as premature ventricular beats or premature ventricular contractions or premature ventricular complexes. A ventricular premature beat is an abnormal beat which arises from one of the ventricles, and it occurs before the expected normal sinus beat. The antegrade impulse, which originates in the sinoatrial node in its normal timing and results in normal atrial depolarization, and the retrograde impulse, which travels from an ectopic focus in the ventricles towards the atria, meet in the AV node. Then neither of the impulses can spread further because of the other's refractory period. Accordingly, the next sinus impulse from the AC node reaches the ventricles in its normal timing, but it would find the ventricles still in the effective refractory period of the abnormal impulse. So it will not be effective, it will be ineffective. The ventricles then would have to wait in diastole for a longer period of time, which is known as compensatory pause, until the next impulse from the sinoatrial node arrives to excite them and start the next systole. So the ventricles would have missed one normal sinus impulse because they would have been in their absolute refractory period because of the abnormal impulse. This is how a ventricular premature complex appears in the ECG. So this is a normal complex. This is another normal complex. This is a third normal complex. Here we have the T wave. Now, after the T wave, after the ventricles finish with repolarization, they begin with diastole, and while the ventricles are in diastole and waiting for a normal sinus impulse, it happens that a hyperexcitable focus in one of the ventricles initiates an abnormal impulse which causes ventricular depolarization, resulting in a premature ventricular complex or a premature ventricular beat. The QRS complex is of abnormal shape and it is wider than normal because it arises from one of the ventricles. Now let's describe a very important ventricular arrhythmia, which is ventricular tachycardia. Ventricular tachycardia is defined as 3 or more beats of ventricular region in succession at a rate greater than 100 beats per minute. The heart rate in ventricular tachycardia is usually about 200 beats per minute, and the mechanism of ventricular tachycardia, the VT, is a high rate of discharge of impulses from a hyperexcitable ectopic focus or a circus movement in one of the atria, in one of the ventricles, sorry. The atria would still beat according to normal impulses originating from the sinoatrial node during ventricular tachycardia. During ventricular tachycardia, pumping of the blood is less efficient because the rapid ventricular contractions prevent the ventricles from being adequately filled with blood during diastole, because the diastolic period would have been greatly shortened. As a result, less blood is pumped to the body, and the reduced blood flow to the body causes weakness, dizziness, fainting. Here we have an ECG strip showing ventricular tachycardia. So the ventricular rate is approximately 200 beats per minute, and the rhythm is regular. The intervals between the successive QRS complexes are almost equal. However, the QRS complexes are of abnormal morphology, indicating that the origin of the arrhythmia is from the ventricles. And I cannot see P waves here. These are QRS complexes. Then finally, let's describe a very important arrhythmia, which is a very serious arrhythmia, and that is ventricular fibrillation. Ventricular fibrillation occurs when the ventricles are stimulated to beat repeatedly and in an irregular and controlled manner at a very rapid rate. Ventricular fibrillation is usually caused by several ectopic foci in the ventricles, which fire independently. As a result, ventricular contractions are not synchronized, resulting in ineffective ventricular contraction and loss of the pumping action of the heart. And when examine the pulse of someone who is in ventricular fibrillation, we will not be able to feel the pulse. If the circulation is not restored in less than 4 minutes through external cardiac compression, external cardiac massage, or by electrical defibrillation, irreversible brain damage occurs and death is imminent. Here we have a 12-lead ECG showing ventricular fibrillation. There are no normal-looking QRS complexes in any of the leads, and this is typical of ventricular fibrillation. So we have now described the arrhythmias which are due to alterations or disturbances of impulse formation. And now let's move on and describing the other arrhythmias which are due to disturbances of impulse conduction. Remember, we have considered the reentrant arrhythmia as a form of arrhythmia due to abnormal impulse formation, and it is also considered as an arrhythmia due to abnormal impulse conduction, because there is also an abnormality in the conduction of the impulse. The arrhythmias which are due to alterations in impulse conduction are further subclassified into heart block, which is known as atrioventricular block or AV block, and we can have blocks in one of the bundles, in the right bundle branch or in the left bundle branch. Let's first begin with atrioventricular block, the AV block. There are 3 degrees of atrioventricular block. First degree AV block is also known as physiologically partial block, where all the impulses originating from the sinoatrial node pass through the AV node but with greater than normal delay in the AV node. In second degree AV nodal block, some but not all the impulses originate from the sinoatrial node pass through the AV node. So it is a more advanced degree of block than the first degree heart block. In the third degree heart block, which is also known as complete heart block, none of the impulses which originate in the sinoatrial node pass through the AV node, and hence the atria would beat according to the impulses originating from the sinoatrial node, and the ventricles would develop their own rhythm, and hence the atria and the ventricles would beat independently. Let's describe the degrees of AV block, the degrees of heart block in more details. In first degree AV block, in first degree heart block, as we mentioned in the previous slides, all impulses originating from the sinoatrial node pass through the AV node but with greater than normal delay in the AV node. So AV nodal delay is prolonged. In the ECG, every P wave is followed by a QRS complex, but the PR interval is longer in duration than 0.2 seconds. Here we have the ECG of a first degree heart block. So this is a T wave, this is a P wave after the T wave, and this is a QRS complex. Similarly, this is a T wave, and this is a P wave, and this is a QRS complex. As we have described in the lecture on the ECG, the PR interval is the interval from the beginning of the P wave till the beginning of the QRS complex. This is definitely a prolonged PR interval. How can we determine the duration of the PR interval? Each small square in the horizontal calibration is equivalent to 0.04 of a second. So we count the number of small squares from the beginning of a B wave till the beginning of a QRS complex, and we multiply this number of small squares by 0.04. The second degree AV block is further subclassified into two types. Mopitz type 1 is characterized by progressive increase in the PR interval until one QRS complex is dropped. In this ECG, we have Mopitz type 1 second degree AV block. This is a P wave, this is a QRS complex, this is a T wave, this is a P wave, this is QRS complex, this is a T, this is P followed by QRS complex, this is T, P, QRS complex, T. The PR intervals are progressively increasing in the successive beats, and here we have one P wave which is not followed by a QRS complex. This is another P wave. Hence, one QRS complex must have dropped here, and this is very characteristic of Mopitz type 1 second degree AV block. In Mopitz type 2 second degree AV block, there is 2-to-1 block or 3-to-1 block. 2-to-1 block means from every two cardiac impulses originating in the sinoatrial node, only one impulse would pass through the AV node. And this is shown in this 12-lead ECG. This is a P wave, and this is another P wave, and this is one QRS complex. So each QRS complex is preceded by two P waves, indicating that the block is 2:1. Again here, in this lead of this 12 lead ECG, this is a P wave, and this is a P wave, and this is QRS complex, and this is a T wave. In this lead also, this is a P, this is a P wave, this is a QRS complex, and this is T. So this ECG, this 12 lead ECG then shows Mopeds type 2, second degree heart block with 2:1 block ratio. In third degree heart block, third degree AV block, which is also known as complete heart block, none of the impulses originating through the sinoatrial node pass through the AV node. Thus, the atria would still beat according to the impulses originating from the sinoatrial node, and the ventricles would develop their rhythm and beat according to this rhythm. So there will be complete dissociation between the atria and the ventricles. In this 12 lead ECG, the atrial rate is approximately 100 beats per minute, while the ventricular rate is about 57 beats per minute. The ventricular complexes, the QRS complexes, are of abnormal shape, indicating that the stimulus which has stimulated the ventricles must have originated from the ventricles and not from the atria. And that's the end of this lecture. And here we have the intended learning outcomes, the ILOs again. And thank you very much for listening.